trying to recuperate my minutes.
Okay.
Lost it. I'll be very quickly. It's a discussion about primary hip replacement in Romania. The evolution of the past 20 years.
Please, yeah.
Is it functioning? This one? Oh, yeah, it's okay. As the general evolutionary overall aspects of the hip endoprosthetic implantation in Romania in the 20 years, existing from data from our national register, it's an upward trend, but also around 50% lost by pandemic period. For it's a list about all the hospitals, private and non-private. The second slide about our register, increasing the patient age at the surgery moment. Here can be put in a question about increasing experience with older patients or the life expectancy it's longer. About women and men, it's predominant for women and is not an increasing factor about femoral fracture, neck fractures, because it's a very small percentage. Private hospital, increasing the number of the patients, double in pandemic years 22-21, probably by using state hospitals for specific medical pandemic assistance for COVID-19. The same distribution in total primary implant in hemiarthroplasty during the years. Paradoxal consist in bipolar hemiarthroplasty increasing in the last 4 years before pandemic period, with relatively same number of more prostheses in a general accepted increasing of the age of implanted patients. Cementless fixation increasing in the years. And here it's another sign of question, if it's a discussion about reduction of the operating time, or in spite of the patient age and supposed osteoporosis, I think it's necessary to put cementless, but maybe remain that reduction of the timing operating in the theater. Significant increase in MIS surgery versus classic approaches in the last 4 years. Lateral approaches remain at the same level like in other approaches. MIS procedure had a major change in 2014-2018 period. MIS directly anterior remains the most used approach in the last 2-3 years. Most of the femoral head sizes remain 28. In general, there was an increasing in the use of the 32 millimeter femoral head 2016-2019 and remain constant ever since. And this is my presentation, was a very short one. I had a lot of comments for everyone, but I'm stopping here because we are late. Thank you again.
Thank
for
you.
Coming and
Thank
for
you, Cristi.
listening.
I would like to make an announcement first. Please, all of you, activate in your mobile phone the location services, yeah, and the Bluetooth, because otherwise it won't be able to be seen by the transducer at the entrance door, and that's why we have the line now. Please do that in order to be okay with the identification by the organizers. Okay, let's go further. And we invite Professor Jedel Pătrașcu. Professor Jedel Pătrașcu with the anterior intermuscular approach. Who are the most appropriate patients?
Morning, everybody. My name is Dan Cojocaru, but I'm going to present the lecture for Professor Pătrașcu. The name of the lecture is the total hip arthroplasty, the anterior intermuscular approach, expectation, reality, and who's the most suitable patients. Few reminders about the approach. There is a complex technique for total hip arthroplasty through the muscle gap was originally described by Carl Hutter in 1817. The Norwegian orthopedic Mario Smith Patterson popularized the approach in the US for the hip dysplasia, and Jean and Robert Judet repopularized the anterior approach in the early 1980s. About the approach, why it's an attractive choice, because I have no muscle section, there is a low pain scale, and the patient can be early immobilized. What we think we know about this approach is not direct. It's a approach with small skin incision. It's important for the patient. Have few complications and great outcome important for the surgeon. And if it's really have a short hospitalization, which is important for the hospital manager, if all of this it's respected, probably this one is the ideal approach, but we will see about that. What we expect after all the papers we know and about this approach, we can feel that we can do almost everything on the anterior approach, but we will see. What we really know about this is a minimally invasive surgery, but with an increased surgery time. Have a small muscle damage. The intraoperative complication rate, especially at the beginning, is pretty high. Some studies say there are no significant difference for the hospitalization between the direct anterior approach and other approaches. Has indeed a low score for antalgic scale, and all the studies say that at 1 year follow-up, there are no significant outcome difference between other approaches. Have a high learning curve procedure. It's a high learning curve procedures, and is more technically demanding than lateral and posterior approach. When the selection of the patient is important, especially in the first cases of a direct anterior approach, that's why we must plan the surgery day and try not to do more difficult cases in the same day. It's important to rate each case in the aspect of the difficulty with A, B, or C and organize them properly. Why the patient selection? Because there is a learning curve. Studies say there that is necessary 40 to 60 cases of the learning curve to get some experience. It's a high risk of complication at the beginning. Why the complication may occur easier? Because it's an approach with kind of difficult exposure because of the big muscle mass or the morbidity, obesity. The patient can have big osteophytes, capsular contraction, that kind of patient with some short femoral neck, acetabular protrusion, with osteoporosis and some modification in the bone architecture. What to avoid in case of the obese patient? Each one of them can be pretty challenging. If you have that kind of patient, probably it's better to consider and get in mind other approach. But if still want to do it, probably we must adapt the incision. The very muscular patients can be very challenging because the exposure on the femoral side can be very difficult. Capsular contracture in oral arthrosis, a patient with oral arthrosis lead to low range of motion. The capsule is not so elastic like in the picture, and it's get contract. This capsular contraction is necessary probably to get some extended release of the capsule. The patient with some short femoral neck, it's also pretty challenging. The picture A, between those patients, probably the first one is going to be more difficult than the second one. The hard exposure of the femoral side can be challenging. The acetabular patient with acetabular protrusion lead to capsular contraction and also hard exposure on the femoral side. Patient with osteoporosis is very important to know about them. before starting the surgery because it's a high risk of fracture. If it's happened, it's going to be very hard to fix on this approach, and probably it will be better to consider other approach. Pelvic anatomy aortic distance, it's something very important. It's about the space between the greater trochanter and the iliac wing. The first patient with the pelvic anatomy working space distance pretty low probably is going to be harder than the second one, which is going to be easier for the direct anterior approach surgery. Patient with big osteophytes can be hard to remove. If it's going to be removed, it can start a bleeding point, which is not so nice on anterior approach. Can have also capsular retraction, and can be a difficult case for this type of surgery on direct anterior approach. Previous surgery, it's important to avoid this kind of patients at the beginning of the direct anterior approach start, because they can have modification in the area, muscle retraction, scars, which gonna have, and we're gonna have a challenge in the surgery. Hip dysplasia, the difficulty of hip dysplasia, it's in correlation with the level of dysplasia. Probably the first case is going to be easier than the second one, and this must to be evaluated properly. Pertech disease also get usually capsular retraction, short femoral neck, and a short pelvic working distance, and it's going to be not so easy for operating on the direct anterior approach. Knowing all of this, probably we can introduce the ideal initiation patient. Of course, she must be a female, thin, with normal muscle mass, no osteoporosis, no previous hip surgery, and normal anatomy. That's why the planning is so important. Knowing all about the complication, planning can make complication avoidable. Few cases in our clinic in the last month. There are two female, pretty thin, with not so big muscle mass, and the surgery went well. In conclusion, we say that the patient selection is very important. Recommend also to start with easier cases and avoid extreme patients, obese, very muscular. Don't forget to evaluate the pelvic working space and increase the difficulty of the cases as experience grow. And yes, you can do almost everything on the direct anterior approach, but not from the beginning. Thank you.
Mulțumim frumos pentru prezentare. A fost într-adevăr o prezentare frumoasă. Urmează head size and tribology. Do this really matter? It's our colleague Vlad Georgianu. It's a very interesting subject. Please, Vlad.
Good morning, everybody, and it's very nice to see you in so large number after a very difficult period of time. We'll speak today about a real hot topic, the head size and tribology, a subject who interests us very much. Everything started from the increased number of young patients who need hip replacement. The main concern for this kind of patient is in the one hand the inability of the patient to return back to sport or high functional demands, and on the other hand, the increased incidence of dislocation and the polywear. These last two aspects increase dramatically the lifetime risk of revision, a concept introduced by Baylis in the last 5 years, by six times, which is very high. The first the direction of evolution is improving the bearing surface. The ideal one need to be chemically stable with low friction. The produced wear debris not induce a host immune response. It is resistant to heavy loading, and the risk of material fracture need to be very low. The cross-link polyethylene was introduced in HIP tribology in the late 90s, and today is considered the gold standard for this field. Represent more than 98% of liners worldwide. The irradiation by different methods induce cross-linking between polyethylene molecules, which increase the wear resistance of the material by 10 times. This is obvious for a revision rate, which is almost double for conventional polyethylene compared with cross-link one. But still, this kind of polyethylene is not perfect. Why? Because the free radicals who are produced during the process of linkage decrease the mechanical resistance of the polyethylene. So there are many methods who try to reduce the number of the free radicals. The most used one is the doping of the polyethylene with vitamin E. This process improved the oxidative stability by reducing the number of free radicals, like I told you. And this kind of polyethylene has shown excellent wear resistance to oxidative stress in laboratory conditions, but the clinical studies does not show a major improvement in mechanical properties. Another step forward was the introduction of ceramic in HIP tribology. Compared with metal heads, ceramic have several advantages, like better compatibility, higher hardness, the improvement of surface finishing. Most important, higher wettability with better lubrication of the surface, less friction and scratching, and less linear wear. Another very important aspect is truniosis, which is mean the fretting and corrosion at the taper head junction. Theoretically, with ceramic, this condition is almost zero. There is no ideal bearing surfaces. The conventional polyethylene are associated with wear and osteolysis. Ceramic increase the wearing resistance, but decrease the mechanical properties. Ceramic on ceramic is associated, carries the breakage and squeaking, and metal on metal are is less and less used today because the general and local effect of raised metal ion. There are very few studies who directly compare the results of different combination of bearing surfaces. A meta-analysis of Robert Truesdell group from 2016 compared this process, and there is no big difference between these surfaces. Regarding the US trend today, Hegman showed that metal on metal is today almost abandoned in the United States, and starting from 2014, ceramic on poly surpassed metal on poly like the favorite bearing surface. The same evolution is around the world, and one exception is the Nordic countries, where the metal on poly is still the favorite surface. But on the other hand, in Germany, ceramic on poly represent the vast majority of cases, with more than 80% of them. The head size dimension is another big concern from the beginning of hip replacement. McKee-Farrar introduced the first metal-on-metal hip with large heads compared with the same diameter like native femoral head, which articulates with a metallic cup. The stability is excellent. The results were excellent for a short period of time, but decreased dramatically over time due to the unperfect surface finishing. channelists make a step forward and replace the metallic cap with a polyware, maintaining the same diameter of head, 42 millimeters, but due to the rapid losing of the acetabular, switch to a small head, 22.5 millimeters, which articulates with a thick polyethylene. The improving polyethylene properties lead to the use more and more of the large femoral heads. Today, the 32 and 36 was the most used dimension. These dimensions represent the trade-off between increased stability and decreased bearing wear. The evidence to support the use of this kind of heads are increased head neck ratio, increased jump distance, and better range of motion. The increased head neck ratio, ideally up to 2, eliminate the risk of neck and of neck cap impingement for the heads larger than 32 millimeters. The threshold is 38 millimeters, after which the impingement is almost zero. Jumping distance depends first of all about on head diameter, but acetabular abduction and anteversion and the head offset are elements who increase this jumping distance as well. In a classic study by Seifert showed that ROM is increased by 1 degree for each increase in 1 millimeter in head size. The functional results are better for larger heads, but the large study, like a meta-analysis from 2019, shows no statistically significant increase in hip function in bearings larger than 32 millimeters. The dislocation is probably the most important aspect, and the early dislocation is completely something else complete and is related, first of all, of course, to the malposition, but head size is very important as well. Late dislocation, it's a completely other story. The studies shows that the revision rate of dislocation is not different between 28 and 32 millimeters between different bearing surface, but meanwhile, for 36 millimeters heads, the rate of revision for metal on poly is large. It's bigger than for ceramic. What is mean? The main mechanism is wear. There are 3 different types of wear: linear wear, volumetric wear, and frictional torque. The most important and the most aggressive are the volumetric wear, which are by far higher for metal on poly compared with ceramic, and for large heads compared with small one. There are different type of wear who directly influence the evolution and the surveillance of the prosthesis. The ideal metal heads are 32 millimeters. Less than 32 diameters are associated with a high rate of dislocation, and larger than this dimension the evolution is due to the aseptic loosening and fracture related to the wear. Same story for ceramic heads. A closer look for hip resurfacing arthroplasty. The excellent functional results of resurfacing is completely balanced by the raised blood metal ion levels and the local adverse reaction to metallic wear debris, who lead to very few indications. And today it's accepted only for active males with large hips. The new approaches are custom monoblock with ceramic and poly included in the bearing surface.
Thank you, Vlad.
The conclusion,
It's a very interesting presentation.
I have 30 seconds more. Three conclusions, if it's interesting. The biomechanical and clinical data support the finding of increased stability and range of motion with the use of large humeral heads. These advantages come at the cost of increased bearing surface, which may affect implant longevity, but more clinical studies are needed to understand the clinical long-term effects on larger heads use the various bearing surfaces.
Very interesting presentation.
5 seconds more. Question?
Not anymore, more. Please, for the other team, Răzvan Nene, dual mobility caps, some news. Please,
Thank you.
Mr. Vice President, be short.
Thank you
Because the
for
others
your-
don't recuperate my minutes. Thank you.
Thank you for your introduction, Professor Stoica. So my presentation today is going to be about mobility cup and dual mobility cup prosthesis. And I know it's not a new concept, but it's very important. I mean, my message today is to highlight the idea that that sometimes, in particular cases, we really need to use it, and it's going to avoid a lot of complications. So it is used for the prevention and treatment of instability in a primary and revision total hip. And it offers also a good stability without actually compromising the outcomes and in the implant longevity. There are a lot of studies that are supporting, of course, the effectiveness of this kind of implant, and usually the concerns regarding this implant, they are related to the dislocation and accelerated wear. So several epidemiological data in 2030 in United States, yeah, they are expected to be more than 500,000 of total hip. So the incidence after total hip instability, after total hip arthroplasty, it's 7% for primary and up to 25% for the revisions. So we are speaking about several risk factors like gender, age, abductor deficiency, surgical approach, and so on. So the history, it was, as you can see, it was developed a long time ago. I told you it's not a new concept, and on the below row, you can see how it was improved, the design of this prosthesis, until the design that we are using nowadays, covered with hydroxyapatite and titanium and so on. So the concept, it's very simple. We're gonna have this double mobility between the femoral head and the poly, and also between the poly and the metallic shell. So related to biomechanics, we have two articulation designs. The head is mobile within the poly, and hard-on soft bearing. If the femoral neck, it's gonna be in contact with the rim of the poly, then it's coming the second articulation. And the headliner complex functions as a large diameter head, increasing the head-neck ratio. So this is the way it's acting a normal hip prosthesis. This is the range of motion. As you can see on this slide, definitely after a dual mobility cup, we're gonna have a really improved mobility. So we are speaking about a lot of designs. Nowadays, we are using this on the below row, this Nove cup with different designs that are permitting us a lot of technical situations. And after this dual mobility, we're going to have a low rate of postoperative instability, a dislocation that it's almost 0, 1%. Also a dislocation of the femoral head and the poly bearing to up to 5%, aseptic loosening just like in the others prosthesis, and excessive poly wear in up to 2%. So also means almost nothing. So the dislocation rate after a revision, it's going up to 30%. So we are speaking about several factors, just like muscular insufficiency, aggressive capsulectomy, bone loss, implantic positioning. And the survivorship at 5 years, it's up to 100%, 98. It means a lot, of course. Dual mobility, and the total hip dislocation rate, it's 5 times higher than in total hip for osteoarthritis. So we're going to find a high risk of dislocation of total hip following tumoral resection because of the bone loss. Everybody knows after extensive surgeries, we're going to face this situation. And also Filippo mentioned about 10% of postoperatively dislocation rate when using dual mobility cups. So we're going to find a lower rates when abductors were preserved, and the higher rates when adductor were sectioned or reattached. So the indications, we are speaking about patients with higher risk of dislocation, neuromuscular diseases, cognitive dysfunctions. This American Society of Anesthesiologists score higher than 3, and of course, elderly patients, I mean over 75 with usually prior hip surgery. And also speaking about revisions and primary total hip after tumoral resection. And we do have to be careful on younger patients that usually really have a higher level of physical activities. So the complications, we are speaking about these intraprosthetic dislocations, and also we're going to find that characteristic X-ray aspect of bubble on the X-ray, yeah, and retentive failure, and sometimes in younger patients, I told you because of the physical activity, we're going to have an increased wear rates. So in this presentation, I included 53 cases. More of them were females, and only younger than 40, only six patients. I did the primary for osteoarthritis, for femoral neck fractures mainly, 12 cases, and acetabulum fracture, 1 case. And when I used it for revision, it was because of failed DHS and gamma nail, failed hemiarthroplasty, infection, periprosthetic fractures, revision of total hip, and arthroplasty and failed osteosynthesis. So what I used, it was acetabular cup between size 44 and 62 mainly. I mean the average was 46 because there were mainly females, and femoral sizes between 8 and 15 with the average on the size 10. So cemented and uncemented and hybrid implants. So for all the patients, I'm using the posterolateral approach, being very careful on the reattachment of the rotators, of course, at the end of the surgery, and partial weight bearing just immediately after the surgery, and with the follow-up, just like we are doing usually 3 months and up to 2 years. So the complications, we had 2 cases of infection, 1 case of dislocation, intraoperatively fracture of the acetabulum, 2 cases, mortality 1 case, and no implant loosening. So here are several cases. Dismobility after femoral neck fracture, also after a femoral neck fracture, and let's say common osteoarthritis. It was a good option at this time. Also an osteoarthritis, and post-infection, I did it in 2 stages. First, removing the implant, the first one, and replacing it with this cemented impregnated stem, and the second stage, and dual mobility cup. Another case, it was after a trauma, pelvic trauma, and acetabular fracture, when after developing that osteoarthritis, secondary osteoarthritis, I chose the dual mobility implant. So in conclusion, it's a viable alternative in preventing and treating hip instability. It's a mid and long-term follow-up support by their effectiveness, and intraprosthetic dislocation and accelerated wear less significant in older, low-demanding patients. And also, I have to mention again, we have to be careful on younger patients because of their physical activity. Thank you very much. I hope I was in time.
Thank you very much for your presentation. We'll go on, and the next presentation is primary hip arthroplasty in patients with renal dialysis, and we invite Professor Dan Grecu to present this work.
Thank you, Dan, for your effort to come here and to speak.
I'm coming by feet, not by hands.
Please do it, but quickly.
Thank you. Happy to see you again after so many years. So why this topic? First of all, disclosure, I didn't get any fund grants for this paper. Why this? because each year about 40,000 patients undergo regular hemodialysis. And the survival rate it's about 60% after 5 years. So more and more patients survive for a long term and are candidate to develop a particular pathology or severe hyperparathyroidism-induced osteoporosis, which is known renal osteodystrophy. The mechanism is complex endocrine, which led to increase of the parathyroid hormone and secondary change in bone stock, change in blood level of the calcium phosphate, calcification of blood vessels, artery, and very severe osteoporosis. So 20, 25 years ago, we didn't perform hip replacement in hemodialyzed or cirrhotic patients. Only this year, we operate 5 patients, and none of them had significant general intraoperative or immediate postoperative complications. Generally, I accentuate. And why this topic? Because there are so many, and the fracture of the femoral neck become a common pathology to these patients, which have some particularities. Often the fracture appear without trauma, evident trauma, only with minimal trauma, and most common is twisting on the hip, as we would see later. Most of the patients, like this? Most cases of the patient needs hip arthroplasty for a neck fracture. In rare cases, we did a total hip for secondary avascular necrosis of the femoral head some years ago. Sometimes the diagnostic is difficult from the beginning because we have fracture inapparent on X-rays. And if the patient is very unlucky, can be inapparent even on CT because sometimes the line of fracture is horizontal and we just cut with the CT through the fracture. We had a patient like this. But the patients come after a few weeks of forced rest bed with deformity, evident X-ray fracture, and this important bone local loss. What is to take care of these patients? We have to have a very careful assessment of these patients because they have a complex pathology. They are immunosuppressed, anemic, with severe osteoporosis, sometimes blood vessel fragility, sometimes coagulopathy, and many times with psychic disorders. They always have a kind of depression, mental depression, and can lead even to suicide. Assessment of the chronic treatment has to take care. This means anticoagulated patient generally, and we have to adjust the dose of all the drugs which the patient takes. Which is the treatment? Of course, we cannot take in consideration only endoprosthesis because due to bone quality, the poor bone quality, reduction of internal fixation is sure failure. What prosthesis? It's first is cemented or uncemented, and I prefer uncemented stem. Why? Even the cemented stem provide primary good stability. There is a high risk of periprosthetic fracture around the tip of the prosthesis, and secondary high difficulties in the case of necessity for revision, sepsis, loosening, or prosthetic fracture. And again, what type of prosthesis? It's partial or total. If the acetabuline is a good or fair condition, I prefer always the fastest procedure, which is a partial prosthesis. Cervicocephalic, Moore type has a lack of primary or secondary stability. Thompson type is cemented and avoided. So the last possible, it's a bipolar prosthesis with uncemented stem. In the most cases, we use primary standard stem, but some cases need from the beginning a revision, long, locked, uncemented stem. Timing of operation. After all the consult, we have to deal with the nephrologist all the time. The timing is next day after the dialysis, because that moment the organism is the best possible condition, and if heparin, if it's used during dialysis, has enough time to be neutralized by the organism. Timing and dose of antibioprophylaxis and antithrombotic prophylaxis and other treatment are established with the cooperation with the nephrologist, which is always there. Our nephrologists are amazing. These patients are like their babies. They are come personally, like it's a family for them. What to what to have to take care to avoid complication during surgery, because we know they can appear even we are taking care, but we have to have to be more carefully about this. We operate, and this is case only for Romania, other state wouldn't be this, but we operate only in controlled operating theater. This means temperature, laminar flow, positive air pressure. We have only one operating room for these cases, the rest are not suitable for this. It's are operated only by experienced team with careful hemostasis, and we additionally use for preparation of the skin microbial sealant cyanoacrylate base, which is much better to keep the surface of the skin sterilized. We use generally spinal anesthesia, but always we are prepared for general anesthesia because also the anesthesiologist is aware about the risk of the fracture in other places to this patient. Most common fracture is the fracture of the femur during anesthesia, during surgery, and so on. We always are prepared with enough transfusion product, which means not only blood, but also fresh plasma and thrombocyte mass. Most common complication during surgery is, like I said, local complication, femoral fracture through torsion. So we have to be always prepared to solve this during surgery. In my opinion, we switch the standard stem to an uncementing long revision stem, which can also be locked. And I'll show you an example for what I said before. A male, 40 years old, 35 history of chronic renal disease, so from childhood, 22 years of dialysis, who had a fracture during matinal toilet through twisting. First X-ray was unconclusive. We did it X-ray and CT scan after 2 weeks, and was obvious the fracture. We make a very careful assessment of the patient. First option was, for this case, conservative treatment, which was a choice some years ago, but for this we've been very, very afraid about what could happen, but the patient insisted desperately. He said he'll commit suicide if we don't operate. And I chose from the beginning a revision lock stem with bipolar femoral head. Why this? This is the case. Doesn't look anymore like a normal bone. That in the right is CT. We have the slides from CT. The bone was completely destroyed everywhere in the body. This is the result after 6 weeks. Of course, we had a fracture. You can see there a fracture occurred on the massive bone loss on the diaphysis. We just used a long stem like a nailing, locked. That was the biggest prosthesis available on our suppliers, the biggest, long and wide. And we also used some graft there, which was fixated with the cerclage. This is the result after 20 weeks, so looks a little bit, the bone is increasing, bone mass is increasing, so it's a very good sign for us. Probably the Titan has property to induce bone growth on the surface. But let's say regular cases, this is a lady who is 25 years old, fall from the same level, also about the same history about difficult treatment, was operated with standard stem, you can see there. When she went down, she went home, fall down on the stairs, had a trauma of the hip, some pain, X-ray was normal, and this is the X-ray about 12 weeks. You can see migration of the stem, evident loosening of the stem because of the poor and difficulties in grow bone on the stem. We didn't operate, was afraid to make a revision, and she also was very afraid. Had, of course, some pain, was ambulating with 2 crutches, and unfortunately, before any other possibility, she died due to the COVID pandemic. So what take-home message? Never run away from this patient. Do not reject them. Make always careful assessment. The technique is standard, nothing special, but very careful to everything, and be sure the patient follows the post-operative recommendation of the surgeon. Thank you.
Thank you, Dan. Nice presentation. And now Vlad Predescu with robotics in primary hip. Please, Vlad. I am very
Good
curious
morning.
what is new.
We know from the beginning that total hip arthroplasty is a very successful operation. We already know this. And at the beginning of this procedure, we were concerned about survivorship of the implant. But nowadays, we have to speak more about satisfaction, which means a satisfied patient and a good functional implant. So in the past, was maybe easier to deal with the patient, but today there is a lot of pressure from the patient perspective, and the expectation of the patients are very high. So they do not want just not a painful articulation, they want actually a normal joint for their whole life. So what can we improve in total hip arthroplasty? We can improve the hip implants, and we know that we have good implants. We can improve the approach, and you have seen that we have today minimal invasive approach. And also we need some device to help us to be more precise. Just to remember, if we talk about dislocation, there is a famous paper coming from Mayo Clinic, and they have shown that almost 60% of the dislocation are in the hip, in the Levi-neck joint position. So we think that cup position is quite good. And also we have a lot of leg length discrepancy. And this is very high concern because the patients are not satisfied. So if we talk about the cup, why it's so important? Because it helps the hip biomechanics, it influences the limb length, it reduces the dislocation, and you have seen how important it is. It means it minimizes the impingement. And also, if we talk about cup position, today we have two concepts. We can put the cup anatomically, but also nowadays, more and more people are talking about functional placement of the cup, and this is related to the spinopelvic movement. And there is a famous classification from the Bordeaux School regarding how to put the cup according to the rollback of the sacrum. So there is a lot of concern about how to change the cup position. And also there are a lot of new surgeons which are trying to measure the spinopelvic movement and to adjust the position of the cup regarding anteversion and inclination, because it has seen that you have a fused or a rigid hip reduced and rigid lumbar spine complex, then you may have dislocation. Just to know, this is the Bordeaux classification, and also the French school tries to change the cup position according to all these movements. So why hip dislocate? Because the surgical approach, and you know, because the cup position, because the femoral version, impingement, pelvic tilt right now, and spine. So we want something to control as much as possible from these variables. We know from the past that we compare the navigation and also the robotics. There are a lot of papers which have shown that if you do something which might help you, then you have a decreased risk of dislocation. So this is a famous paper coming from 2019. So there are three critical elements in robotics. We can have a good preoperative plan, we can have intraoperative and the workflow, and also the execution. We have since 2.5 years in our clinic the Mako Smart system. And this is a workflow generally, it starts from planning, it starts from execution. There's two types of workflow. One is a fast workflow where we can navigate just the cup, and the complete workflow where we can navigate the cup and the stem. So there is a very good preoperative planning where you can do and where you can understand before the surgery how to put your cup, how to put your stem, to choose the fit and feel of the stem, and in order to know the right dimension for your patient. Also, when you talk about cup position, you can choose the best place of the cup, and you can find the anatomical center of the cup. And then same, this is a virtual model. If you, after you've done the planning, you can see how it will look your replacement. Also, you can measure everything. Everything, I mean the leg length discrepancy. You can know what you will do before you're going to start the surgery. During the surgery, you have also digital rules, so you can choose your neck cut, and you know where to cut your neck, even if you are in a posterior approach or if you are in an anterior approach. Then this very nice feature is you have the neck resection view. So according to your planning, you know how should be the anteversion of your stem and how you're going to enter during the femoral canal. Also, the new soft, it's including the pelvic tilt. So as we were talking previously, you can choose for a functional approach, and you can choose according to the pelvic tilt if you need to change your cup anteversion. So this is a pelvic tilt, take it into the consideration before execution. And here you have 3 poses where you can see how it will be your cup during standing, sitting, on the chair, and during the walking, in order to know if it's in a good position. Also, another very nice feature is to check the virtual range of motion. And in the next slide, you can see the robot, it's mimicking you the range of motion, and you are able to see if it's an impingement. What is with red, it's an impingement, and you can see if it's an impingement on the liner or on the bone, so you can know before starting the surgery where you're going to have problems. So then you have the pelvic registration, it's like in navigation, and there is another nice thing is that you do a single reaming, so it's just one reamer. With one reamer, you ream the acetabulum, and then you put the cup. This should be a short movie to see how we remove the bone. What is in green, it's actually the bone which have to be removed, and you have to watch with your eyes, not into the pelvis. You have to watch the robotic display. So then it's coming the cup impaction. It's also controlled by robotic arm, and so we started almost 3 years ago. Of course, we are out a little bit from the learning curve, and now it's not so long, the procedure. And we had also 2 cases where you rush, we smashed the antenna, and then we have to change to the manual technique and to cancel the robot. This is one case. It's a regular case, nothing very difficult. You see on the red, we are able to measure the leg length. Then you decide what type of implant and how you put it. Then you are able to measure the leg length, and then finally you see it's 0. So we were almost able to equalize the leg. This is the position of the cup. With what is with red, it's a bone which will be taken with a reamer. And in the end, it's what we plan. We plan a 0 leg length discrepancy, so we are very sure that will be a good case. This is a post-op X-ray. This is another case, similar osteoarthritis, same planning. You see with red what type of bone we remove. There are a lot of cysts, so we're going to graft the cyst. Same, the planning, the leg length, the final aspect of the X-ray. Maybe will be interesting for the future if you're going to use the robots in dysplasia, where you have a lot of bone destruction. So like here, it's a dysplasia. I was not able to know if we'll be with grafted or we'll be able to do it with a big cup. So we did a plan. We were able to see that the cup can be put into the socket. So we were able to obtain a good press fit, and this is the final result. So the main advantage, I would say, it's a better preservation of the bone stock. We can have the combined offset, and we know what we are doing. We are more precise, and there's more accuracy. So here it's a lot of papers which they have shown that it's a better control of the cup position, of the leg length. There is less dislocation rate. Actually, it's a 0 dislocation rate in the robotic group. Also, coming from the patient outcomes, there are a nice paper comparing 100 cases, and we have seen that from the patient perspective, all the scores were better in the robotic group, except the surgical length in the robotic group were with 15 minutes more. So to conclude, We know that total knee arthroplasty is a very successful procedure. Still, we have complication. We talk about dislocation, we talk about leg length discrepancy and also long-term survivorship. Robotics, it's a promised solution, but still the robot is a tool. So we have to understand what we are doing. And then if you do well and you understand what you are doing, then you can control also the robot. The robot is not the answer for your mistake. There is a better accuracy, there is a better reproducibility and predictability of our position. We can preserve such a tabular bone stop because you rim less. Even they have compared the blood loss is less in the robotic group compared with manual group because you rim just once. Still, it's a longer operative time, and when you are out of the learning curve, around 15 to 20 minutes, it's a little bit longer. There are a lot of costs because the robot is very expensive. And also, honest being, there are not long-term randomized control studies. So probably in the 20 years, we will know exactly the answer for this topic. Thank you.
Thank you very much for your presentation. We'll go for the next presentation. It's Professor Radu Preșbeanu, who will talk about fast-track surgery in primary hip replacement. By the way, all the questions and discussions, questions from the floor, will be done at the end of all the presentations. So in order to respect the necessary time for everybody. Please.
Thank you for inviting me to present this paper. I think in this time we need to preserve our time, patient time, and also we need to preserve the resources because the resources is limited. So in all world now it's the time to do something fast. But why fast? Because the time actually is the most extravagant and costly of all expensive. If you lose the time, you don't have it back. So once it's gone, it's gone. So it's not a new idea. In Lancet, more than 25 years ago, a gastroenterologist say we need to do something to rush the things, to do, to coordinate all the effort to go to the patient to go home. So actually, we need to learn how to do fast-track surgery, not only in the hip, but now we discuss about the hip. We discuss about the definition, the components, and how you make it. We have some aims. So first, you need to enhance the patient satisfaction, to decrease the pain and the stress, to enhance the recovery, and to decrease the lower rate of complication. Of course, you need to reduce the cost and reduce the loss. So how we can do it? We can think pre-operatively, we can do something operatively, and we can do something post-operatively. So some guys who actually thinks about this say, let's do a plan. So plan is to don't implement it from day after first day, to make a gradual implementation, to do a multimodulary approach. But we have diverse hospital setting, we have sometimes no clear criteria to discharge, we have lack of preoperative patient information in Romania, so all this data must be collected, and after that start to do an workflow. So the workflow have three components: preoperatively, intraoperatively, and postoperatively. Of course, at the end of the process, you must follow the patient and collect all the data. We need multidisciplinary teams, not maybe like this in some Timișoara have a fashion week. My daughter is in fashion, so he sent me a film, say, this is your team. But we need a surgeon, we need a good anesthesiologist, we need a pain team, we need a good physiotherapist, we need good nurses, and of course we need a good cooperation with the patient. So how can you do it? We have a lot of effort papers, a lot of effort instructional courses. So we have now a fast-track papers in hip surgery in F4 Society. We need a 30-60 degrees optimization, which means the preoperative, perioperative, and of course we need the ERAS. In preoperative optimization, we know that 45% of patients have some factor risk we can decrease before surgery, like smoking, alcohol, BMI increasing, anemia, and all these factors we can manage before the admission in the hospital. So in perioperative optimization, we can make the surgery in the same day. Approach, it's important, but not so important. You know, you put the hip for 25 years, not for 6 weeks, but it's very important to do it well. Anesthesia, it's okay to do it spinal, but also the general, so that have not contraindication for fast-track surgery. The pain control, we talk about pain control, and the mobilization in first day, it's mandatory. You don't do your patient to the intensive care unit. Go directly to the room, and after the anesthesia is going, you can go with the patient on make some steps. Of course, ERAS and chance recovery after surgery, they say society who have the base in Stockholm. He started in 21. The aim is to develop a perioperative care and improve the recovery to research education and audit implementation, because now we can talk, but we need to have data to prove actually we can say. So they emit some guidelines in 2019. So they bring all the data, and they make a consensus. So we have strong recommendation to have a patient educated before surgery. We have high recommendation to stop smoking 4 weeks before surgery, and to stop painkillers before surgery, expect if you have drugs. And also we have high recommendation to corrective anemia before surgery. The same ERAS consensus say that we don't need preoperative rehab for hip surgery. We need to tell the patient to don't eat 6 hours before surgery, don't take fluid 2 hours before surgery, and it's important to give some preoperative pills to decrease the stress and anxiety, and also to start to multimodal pain therapy. General anesthesia is indicated. It's not more indicated to have peridural postoperative analgesia, so you stop it at the end of the surgery. It's not indicated to put opioid in rahi anesthesia, and for hip, it's local injection anesthesia, LIA. It's not so well proof, so I stopped it to do it. But it's indicated to do tranexamic acid during the surgery. Okay, but I'm surgeon. What actually is my problem? So my problem is to deal the approach, to deal the blood loss, and to deal the pain with the patient. So we have a good team. This is my anesthesiologist and my nurse. Actually, you need a synergist effect. If you have 2-3 things in one thing, you have less complication and more effects. So we know that the pain start to the brain and go to the and to the receptors, but you need to weaning preoperative narcotics, to make a preemptive analgesia with paracetamol, pregabalin, celecoxib, or other non-steroid anti-inflammatory. You give the patient rahi anesthesia and postoperative acetaminophen and ketorolac. Mini invasive approach, less invasive approach. My approach usually is an anterolateral approach and lateral approach. The bleeding, it's important. The bleeding before surgery, you don't start the surgery if the patient have less than 10 gram. If elective case, you use tranexamic acid at 10 minutes before the cut and at the end closure of the wound. avoid hypothermia of the patient. We, like a surgeon, we need temperature, but you must avoid small incision. I use drain. They say you can stop the drains. You can remove the drain 24 hours to decrease the infection. Rehabilitation, we start in first day when he admitted in the hospital. We start in the first day in the lobby, and the second day stairs, and go home. Go home quickly because it's safe, it's sure. But you are sure that it's effective? Yes, because the paper, so that you can reduce the cost, no increase of readmission rate, you decrease the morbidity and mortality. So in summary, we save the time, we save the resources, and save the money. Not the money from the patient, not necessary, but the money for the system. You can do other things with that money. You can do other things with that time who you have it. Thank you for attention.
Thank you. Thank you, Radu. Now I introduce Professor Radu Rădulescu, timing of checkup, visit after total hip replacement, an up-to-date review, please.
I'm sure that all of you in this room are doing total hip replacements. Why should we call the patients after the surgery to be seen again? There are two kinds of reasons. Patients' reasons, I mean, they usually come to see you again if they have a complaint, otherwise they won't come. Or the physicians, or let's say the orthopedic surgeons' reasons, in order to ensure that the outcome of the implant is okay, and that no complications have occurred during the time from surgery to the moment of the checkup. We still lack a consensus about the time when we should call the patients for the checkup, especially about the time of the visits and the nature of the visits. I mean, what should the visit be consisting in? Only physical examination, X-ray examination, or maybe some additional examination that will be necessary to assess the validity of the implant. Even if this kind of arthroplasty is very successful, we still have a lifespan, like we say. I mean, this arthroplasty is not for life. We have very much prolonged the validity of this arthroplasty, which is going towards 25 years by now. But still, there is a certain time when we need to replace the implant. And what we want to see during our checkups is to find out that peculiar moment when is the best time to replace the implant with less bone loss and with a very lower impact over the patient. What we are interested from our point of view, first of all, would be to detect during the checkups those changes which are asymptomatic. Because usually during this change, asymptomatic changes, we can talk most of the cases by, let's say, aware of the liner only that can be replaced. So without being necessary to do a revision of the metal back or the stem. Because the others will lead to a major surgery, which will be cost-effective, very bad, and which an impact of the patients, especially if they are old and with a fragile biology. Here you can see that the patients come for the checkup more seldom and seldom after the surgery. So at 1 year, the checkup will be done by less than 2/3 of the patients. At 2 years, around 1/3 of the patients will be present at the doctor for the checkup. What is the checkup consisting in? Interview with the orthopedic surgeon. Well, in Romania, usually the patient comes to the same doctor that he was operated by. In other countries, you know, one doctor will see the patient before the surgery, other doctor will operate the patient, and another one will check the patient afterwards. Well, in Romania, there is a very close relationship between the patient and the doctor. We may even say they become in time a sort of relatives, you know. So that's why the patient comes always to the same doctor. And besides the physical examination, in which we can use a clinical score, which whatever it is, doesn't matter, even the very well-known Harris score, in order to assess the clinical status of the patient. And we can do the X-ray examination, which some people say that they are useless because the changes that we can detect on an X-ray are very slight, and it's very difficult to see with the eye without magnifying or something, changes at the interface between the prosthesis and the bone that are in fact reflecting the real anatomopathological changes. But still, even in Romania, I mean, we always do X-rays when we call the patients for the checkup. When the X-ray is doubtful, so we suspect some changes, but we cannot assess them exactly, then probably we go further for a CT scan. The checkups around the world are very different. For example, in US, the patient is called at 2 weeks, 6 weeks, 1 year, 5 years, 10 years, and then every year. In Australia, at 3 weeks, 1 year, 10 years, so no checkup between 1 year and 10 years, then every 2 years. In UK, in the first year at least once, then at 7 years, then every 3 years. In Netherlands, at 6 weeks, 3 months, 5 years. So, like we do in Romania, I think we are very, very Americans. Yeah? I mean, we use very much the protocol that is used in the United States. This is, what I said before, is the checkup schedule for the regular patients. But there are, beside those patients, there are the so-called high-risk patients. Those who have, especially the young patients, you know that the young patients may get problems of the prosthesis earlier than the others, then females due to osteoporosis, obesity, strength sport activities, corticosteroid, immunosuppression, renal insufficiency. And also things that are related to the implant, like bilateral implants, small femoral heads, it was already mentioned this, suboptimal alignment of the components from the very beginning. So the immediate post-operative X-ray showed that you didn't implant exactly perfect the prosthesis. So those are also high-risk patients. And finally, the metal-on-metal arthroplasties, which are mainly abandoned now, but we still have patients that we have to check up. How we do this consensus in Romania? Do we have a consensus in Romania? We are looking for the consensus over the world. But the question is, do we have it in Romania? Well, I can tell you, probably everyone else can tell what he's doing. I can tell you what we are doing. So we are seeing the patients at 2 weeks, because usually we need to remove the stitches. So they come to the hospital or to the outpatient unit to remove the stitches. At 6 weeks, we do a clinical and radiological checkup, the same thing at 3 months, 1 year, and then every year after surgery. Well, probably this very close checkups of the patients is due to the fact that some come from remote areas, from the rural areas, from the countryside, wherever. So we need to keep the patient close. Well, if they come, but of course most of them won't come to these checkups regularly. What can we say after checking the literature in different parts of the world? The follow-up schedule is organized arbitrarily according to the consensus of the surgeons. For example, now we will discuss for Romania which protocol will check will bring in discussion. Current guidelines don't recommend more than 2 radiographs 10 years after surgery, like you could see in the previous slide. So what we are doing here in Romania may be excessive, but I think it's normal if we want to get complications very quickly. The high-risk patients are recommended for very closer checkups. But again, let's define the high-risk patients. It's a big discussion here as well, if the patients may be included in the so-called high-risk patients. And finally, like everyone in our days, we need to develop a data-based recommendation for clinical and radiographic follow-up after hip replacement. So we need to do evidence-based protocol for these checkups of the hip prosthesis. Thank you.
Thank you, Radu. We are in timing now. We have another 4 minutes for some questions. I saw that some colleagues put that questions, and I'm trying to find them because I was in other function of the phone. Just a second. I saw 2 questions from our colleague Octav Rusu. Put it in live and Q&A. Oh no, 3 now. Can we have from organizers a microphone and to be directly put it again by the Cosmin Faur? Are you here? Please do it directly with microphone and to know where it's your address. Renal osteodystrophy. Yeah.
If you decide to go for a non-cemented one, do you choose a fully coated or a proximal coated implant?
Okay.
Because we cannot rely so much on bone ingrowth in those type of patients, and we might have problems if we use a non-cemented implant.
Okay, Dan, are you here? Can you respond directly, please? I'm sorry, I invite you to the coffee break to put directly the question, please. The other one, Octav Rusu, please, do it.
Întrebarea mea este, care este combinația dumneavoastră preferată pentru materialul capului și materialul linerului? Cine ce folosește vis-a-vis ceramică?
To all of us?
Of all of us, yes. For all of us, the question is...
Who is starting? But very quickly. We have a Vlad, 2 Vlads.
Ceramic on poly and ceramic big head.
Okay, we can make a poll vote, but we was not prepared for that question. Maybe in another session to put that question before and to stabilize what is voting finally. If you ask me, I think after research in the registry is not a very big difference between them. After 20 years is not a big difference. But attention, to be put it in the correct position is not a difference between 32, 38, 36, 22 or 28, but to do it better in a very good position. Starting with 60s, Charlie said that it's necessary at 22, with a lot of reasons. With our technology from today, I think it's not a big difference. You can believe in all the products because there has his own history, but I didn't realize in my cases a big difference. Please.
I would say it's better not to use the same material for the friction couple. I mean, it's better to use, for example, the ceramic in combination with the e-poly, for example, or if you have metal on poly. So I don't think that using ceramics on ceramics is still a good combination, I mean, from the experience we have. So different materials for the head and the liner.
About this question, if I have just 1 minute to respond, Octav, I think the head dimension is very important, and I think 32 for a metal head it's mandatory. Forget about smaller head than 32, combined with crosslink or E-dope poly. In terms of ceramic on poly, there are not big difference between 32 and 36, but compared to ceramic on ceramic, it's a big difference about the position of the cup. If it's too much abduction, the linear wear to the cup liner, it's very high, and it's a huge step forward to wear also the ceramic. So if Professor said about the ceramic on ceramic, if it's in good position, ceramic on ceramic is perfect. But if it's not in the right position, can be a disaster.
Everyone, I think, like conclusion, must be put it in a good position, in a very correct one. With robots, without robots, with guided machineries, with telemedicine, or with other new devices invented to help us. Important is our vision, our positioning of the patient, and the future of the prosthesis remain in the hands of the decision and making by the surgeon. No anyone will do it alone. Decision and how we are making. But can be a good subject for the future Congress, and I promised you that we are thinking for that in scientific committee to take some subjects like this one. And the other one, your question, please.
Just a moment. We never start from the presumption that the prosthesis is badly implanted. So we start from the presumption that it's correctly implanted. So
yes, I suppose that your intention are concretely found in the final product.
They are showing that actually, for example, in particular cases, just like the hip dislocation and so on, as Professor Radulescu mentioned, definitely you're choosing, I mean, you presuming you're gonna make a better, the best positioning of the implants, but sometimes, in this case, a dislocation, for example, you presume that your position is not going to be the proper one. So in that situations, I mean, me, myself, and also I saw a lot of recent studies on these topics. They are preferring to use ceramic on poly in order to reduce the poly wear in time. Otherwise, if you think and you presume from the beginning that you're going to have the best positioning for the implants, then no, metal on poly, it's enough. Yeah.
But the high-end option is, the ultimate option is ceramic on poly.
Yeah, definitely.
Okay, the other question, put it also about Octav.
all the prostheses will be perfectly implanted with the robots.
You have a lot of time in the coffee break to joke or not about science. Thank you very much for this session, for all of you, for your presentations. See you later.